Hello and welcome to Healthy Living. I'm your host, Dr. Donald Pelto. Today we're going to be talking about a relatively new topic called regenerative medicine. I have the privilege of having two guests with me, Dr. Neil Feldman and Dr. Benjamin Saviette. They're both board-certified podiatrists, and they're going to join us for this conversation today. We're going to discuss some of the newest types of treatments to help athletes recover quicker from injuries and many times avoid long surgical recoveries. So first we're going to look at what is regenerative medicine. To start, I want to define regenerative medicine, but I would ask either of the doctors to contribute as well. Regenerative medicine is a game-changing area of medicine that can help heal damaged tissue and organs for people that thought their conditions were beyond repair. One aspect of this regenerative medicine involves boosting the body's natural ability to heal itself. For example, if you get a cut on your finger, it will usually heal in a few days. However, other tissue, for example, on the bottom of your foot, if you're a diabetic, can be slow healing. Using a specially engineered covering on the wound can boost your body's natural healing process for this wound. Here's a picture of this type of a graft that is used on a foot wound. Another type of regenerative medicine involves replacing damaged tissue or organs from living or deceased donors, such as a heart or a liver transplant. If these heart or liver cells could come from the patient's own tissue, that would help solve the problem of tissue shortages for organ transplants and also the problem we currently have of organ rejection. But today specifically, we're going to talk in our conversation about the regenerative process inside of tissues. This involves delivering stimulated specific types of cells or cell products to go to diseased tissues where they will restore the tissue function. Remember, the goal of this area of medicine is to stimulate the body's own repair mechanism to heal something that previously couldn't be repaired. We are going to focus on three modalities within regenerative medicine. The first is going to be platelet-rich plasma, the next is shockwave therapy, and then finally we're going to talk about amniotic membrane therapy. First, I'm going to ask Dr. Feldman to talk a little bit about platelet-rich plasma therapy. So if you could first just start out explaining to me, what is platelet-rich plasma therapy?
All right, thanks, Don. Thank you for inviting me to the show. Platelet-rich plasma is also called PRP, and it's taken from your own body. We would draw blood from your arm, most likely your arm, and there's a centrifuge that we have in the office, and it'll get spun down. Plasma is your blood taken out of your body and spun so the red blood cells are separated out. The red blood cells are heavier, so they end up at the bottom of the test tube. And there's a yellow liquid. It's the blood components without the red blood cells that has, it's called plasma. And inside of that is a larger concentration of platelets. We take that and then we'll inject it into the diseased tissue, and the tissue being tendon, fascia, ligaments, or joints, or even bone for that matter.
And so with this platelet-rich plasma that you get, does everyone, if you take it from me and from Dr. Saviette and from yourself, are we all going to get the same amount and same quality of platelets?
No, it's going to depend on your body. Our platelet production is different for all of us at different ages, different cycles. It's based on a lot of different factors, how healthy you are, for instance. Some people have low platelets. Some people have excellent platelets. We don't typically get blood tests on people to determine their platelet count, but that's an area that could be explored. We're going to talk about it later, but that's what's so exciting to me about the amniotic membrane therapy, because it bypasses your own
using your own blood.
Using your own blood, and it saves the blood draw as well.
So once you have a patient and you take out the blood, you spin it down, you get this magic gold. Where would you want to inject it? Why this type of treatment and not a different type of a treatment, maybe like cortisone or something else like that?
Yeah, and in today's day and age, people are very leery about chemicals being put into them or anything that's going to be damaging or toxic to the body. Cortisone is wonderful. It's an anti-inflammatory, so it stops the inflammatory process. It can help reduce localized inflammation, and it can help with symptoms. There's no doubt about it. The problem is it also delays natural healing. It actually interferes with the body's natural healing response. Platelets are what promote the body's healing response. We want platelets to be called into the area because we want platelets to bring their growth factors, their special healing properties. They release their own stem cells. And stem cells are cells within your body that can become other types of tissues. They're called multipotent stem cells, so they can become bone, tendon, fascia, ligaments, joints, nerves. They can't become organs, not in today's day and age, not yet. Hopefully never, but or hopefully someday with the organs. But
So you take this special platelet-rich plasma, and then you inject it into, is it a tendon, is it a bone? What area of the body specifically do you use it for?
So if you have plantar fasciitis, it can be put right into the source of the plantar fasciitis. And nowadays it's really exciting. We have a diagnostic ultrasound at the office, so we can literally see the area of concern, whether it's plantar fascia, whether it's a tendon tear, whether it's Achilles tendon. We can literally see the structure, and we can see the disease part of the structure. We can see the needle going in to the structure. A little later we'll show you an Achilles tendon where there's actually amniotic tissue going in, but we can do the same thing with platelet-rich plasma or PRP. So it's any of the tissues you need it to go into, we can put it into those tissues.
And is this something that's done in the operating room? Is it something that's done in your office? And what's the recovery like afterwards? Do you have to be out of work?
Yeah, you can do it anywhere. We actually do it right in our office. We have the ultrasound machine in our office. MRIs are typically the gold standard diagnostic study where you can see tissue disease. You can see tears in tendon, you can see splits, you can see inflammation, you can see cracks in bone. But the diagnostic ultrasound gives you real-time imaging capabilities, and we have it in our office, so you can do it right in the office. It's a blood draw. The spin on the centrifuge is about 5 minutes. So the blood draw, it's me drawing the blood. So if you're an easy stick, it's pretty quick. Sometimes it takes a little longer if you have a difficult vein. The spin itself is about 5 minutes. Sometimes we'll use a local anesthetic to the area to limit any discomfort that might occur from injecting it. If it's a larger area, if there's multiple areas within the plantar fascia or the Achilles, then PRP is a really nice choice because you usually we draw 15 cc's of blood. So that's about 3 teaspoons of blood. And that gets spun down. Typically we get anywhere from 3 to 5 cc's of plasma of the PRP, which as you mentioned, we call it liquid gold because it's a golden color. And that gets injected into the areas. So if there's larger defects, that's a really nice option to have. The procedure itself takes, if we're doing it under ultrasound, it might take a little longer, but from 30 seconds to 3 minutes. Afterwards, you get a Band-Aid or a soft wrap. Depending on the structure involved, you might go into a soft cast and a walking boot for up to 2 weeks. And as you're walking out,
that's what it is.
You might need a ride if it's your right foot, because you might need to be in a walking boot on your right foot.
And is there anything you can't do after? Can you take Motrin, ibuprofen, things like that?
You shouldn't, because again, those are anti-inflammatories. You could take Tylenol. You could use ice or heat, but we generally don't like the use of the anti-inflammatories because it will interfere with the function of the platelets. And the other thing I might add is the disease structures, the tissue tears, fasciosis, fasciitis, Achilles tendonitis, tendinosis, they're just conditions of pathology within these structures. The reason they become problematic in the first place is they don't have a great blood supply. And platelets get called into action to heal, but they need to come through the bloodstream. They need to come through capillaries. And if these structures don't have a really powerful or strong blood flow to them, you're not going to get nearly the quantity of platelets there that are needed for healing. Platelets release fibrin, and they also release factors that help with new blood vessel formation. So they actually promote blood vessel formation from within these tissues to increase your body's own ability to heal itself, and that's one of the real exciting features, and that's something that the shockwave therapy also does, which we'll talk about.
I think it's a good segue. Dr. Saviat, do you have anything else to say about platelet-rich plasma?
Well, first, Dr. Pelto, thanks for having me on the show.
You're welcome.
Much appreciated. Big fan. Been posting a lot of the videos. About the platelet-rich plasma therapy, the people who, in the general population, who have probably heard of it the most are the people who are sitting at home on their couch on Sunday watching football. And you hear about, Martellus Bennett's out getting platelet-rich plasma therapy into his shoulder, or Vince Wilfork had it into his Achilles tendon after it was ruptured. These elite, high-level athletes. These guys, obviously, sometimes they have an infinite amount of resources to do anything to heal themselves, but some of these things, they make sense to the guys that want to get back out and participate a little faster. So.
And also maybe avoiding surgery. In the past, if you have one of these tendon injuries, a surgical option is what you were doing in the past, sooner.
Yeah. These athletes, too, were flying to Germany because the initial work was done over in Europe, Italy, Germany, and they were Tiger, Lance Armstrong, in addition to other things probably. Yeah. But these procedures.
Now you can have it in Worcester, Massachusetts.
Not the stuff Lance was on.
Yeah,
not that.
We don't do that.
Well, good. I think it's a good segue now to talk about our next topic is something called shockwave therapy. And Dr. Saviat, he's kind of researched just a little bit, and he's kind of at the forefront of shockwave therapy. So I'd like you to start talking a little bit about shockwave therapy, Dr. Saviat.
Absolutely. So I've been a big fan of shockwave therapy for several years. I've done multiple presentations and research projects on it myself, and been pretty much up to my eyeballs in it for a few years now. So was excited to join a practice where shockwave was a component of the practice. So what shockwave therapy is, it's not somebody just in there whacking away on you with a mallet or anything like that. It's a way to manipulate some of your soft tissues, be it a tendon or wound or a bone or a ligament injury, to try to stimulate a physiologic response that's innate and kind of already within your body, to get it to respond to an injury that might be there.
So let's, we're going to show a picture right now of an actual shockwave machine that we use. And could you explain a little bit how it works? What are the mechanics of it?
Yeah, so there are several different types of machines, but the machine we use in our office, it has a handheld device, essentially, that's connected to a machine. And then the machine provides a pneumatic flow of high pressure and low pressure. And what that does is it moves a projectile within the handpiece.
It's a little piece of metal.
It's a little, basically a little BB that oscillates back and forth within the handpiece, and you keep that handpiece in contact with the skin, and the projectile will hit the tip of the device, and then that creates basically a concussive wave that goes through your tissues. And that's the very easy explanation of it.
Yeah, and so those waves, you put a gel, ultrasound gel on there to conduct it?
There's a little conductance gel which just helps that energy really effectively get in there. You lose a lot less of the energy when you use a conductance gel. If you don't use a conductance gel, then you lose some of that energy to sound waves and the like.
Mm-hmm. And how was this first used, this technology? We're using it on the foot and ankle and tendons and things, but where was it first used?
So it really developed in the early 60s, I believe. They were using what are called focused shockwave machines, and what they would do is they would submerge a person into a tub of water, and that was their conductance gel, essentially. And they used an ultrasound, or rather a fluoroscopic X-ray device to target kidney stones, and then they would shoot a high level of energy at a focused distance, and it would come together and hit this kidney stone, causing it to oscillate and fragment. So rather than passing a lima bean-sized kidney stone, which I imagine is probably pretty painful.
It's really painful.
You end up passing sand. So it fragments that calcium-based kidney stone and causes it to break apart, and then you can pass it without much pain. So that's where it developed.
Yeah.
But what they were starting to see is some of these people who were in these tanks were relating, oh, hey, my lower back pain is starting to go away. And then some other folks got got kind of wise to that and started using it for different things. The earliest research after that was in calcific shoulders. There's been some stuff on lateral epicondylitis, so tennis elbow, and then from there some different entrepreneurial doctors started using it for different things. They said, hey, I'm reading about this, let me try it for plantar fasciitis, let me try it for Achilles tendonitis.
And that's how you primarily use it?
Yeah, so initially I kind of got wise to it for plantar fasciitis. Plantar fasciitis is one of those things, 90% of people get better with the standard of care treatment, whether it's physical therapy, steroid injections, night splints, some home stretching, foam rolling. 90% of people get better with that. There's the 10% then that end up in this chronic phase where it's not improving after about 6 months. And then you tend to see research on that 10% of people who don't get better with things.
Okay.
And it's been utilized a lot in that population. So people who were not improving and then they got shockwave therapy and they start to improve.
And so what do those, if we're talking about the kidney stones that get targeted and they get broken up, what are you doing with the fascia? Is it breaking it up? Is it causing an acute injury?
So it's not so much causing an acute injury. I have heard that before. It's kind of an easy way for a doctor to explain what's about to happen physiologically to you. And I've been guilty of it myself at times to say, hey, here's the long and the short of it. I give the Cliff Notes version. But in reality, what this is it's not so much causing an acute injury as causing your tissues to respond as if there is an acute injury. So when those physical energy waves from the impact of the projectile get to your tissues, your cells respond to it. Our cells are always responding to the environment that we live in. So if you start to run a lot, over time your bones become more dense to accommodate that level of forces that are going through your body. So this is very similar, except it's a high level of energy focused into certain tissues. So that mechanical energy then gets translated into chemical signals that our body responds to and causes a healing response in a lot of different tissues.
So let's try to simplify this down. So you hit a piece of tissue, whether it be an Achilles tendon or a plantar fascia, you hit it really hard. For how many times do you hit it? Is it usually 20 minutes, 5 minutes?
Depends on how many areas we're treating. The standard for most injuries is around 2,000 shocks. And we do it at a frequency of around 10 hertz, so you can pretty much hammer through that in about 5 to 10 minutes if you're working hard.
So you do that, and then there's a response from your body. What happens? What does your body do after
So
that?
the whole cascade is very elaborate. Oh, yeah,
we're going to put a picture. Let's put a picture
up
of the cascade, so you can explain that another day. You can email him if you want to learn it.
It's mind-numbing. It's kind of the thing. Who needs Ambien when you have chemical cascades,
yes.
right? What it does, the main thing that it does is it creates a vascular ingrowth process through this chemical signal called VEGF. I don't want to bore you with what it stands for, but it creates this cascade of events. So what Dr. Feldman was mentioning before about creating where there's an area that there's dysvascularity, not good blood flow, we're trying to institute some better blood flow. So really you're getting little arterioles and capillaries that grow in and begin to heal that tissue with better blood flow to that area.
So kind of comparing the two with PRP and then with shockwave, is it one treatment for both of these, or is it multiple? And how long do you have to wait to see the results for either of these?
So PRP is usually a single dose treatment or several months apart with doses, if I'm not mistaken.
Yeah, it depends on the tissue, it depends on the extent. I might do 2 injections over the course of 3 to 4 weeks separation, or 6 weeks. I might just do the one as well.
And for shockwave therapy, it really is dependent on what the particular injury is. So if you have an Achilles tendonitis, usually the standard for that is once a week for 3 weeks. There's different literature that says once a week or once every 2 weeks for 6 weeks. But what the literature is pretty clear on is that it can take 6 to 12 weeks for you to really see a result with
So you have to be patient.
With shockwave therapy. So you need to be a little bit patient with it, but the results really are there for injuries that are both chronic and acute. You get a lot of high-level athletes that have an injury that's not responding, and they want something done to just get the stupid thing to heal so they can get back to what they want to do. So there's a lot of that.
Yeah, this typically isn't a quick fix. This is regenerative medicine. Your body has to heal itself. This isn't a movie that shows healing in a lab, and it takes time for your body to heal itself. So
and it's probably going to be for those patients then are going to want to avoid surgery. So this is kind of like the last step before surgery for a lot of these.
It can be. That being said, if you're a high-level athlete or you're a semi-professional, or you would go nuts if you couldn't run every day like some of us, you kind of need your medicine out in the woods to go for a run. So some of those people, it's worthwhile to, if it starts to hurt, come in and get it treated early. It's kind of the penny of prevention. In
this one, there's no drawing of blood. There's nothing. It's a machine. Takes 2 or 3 minutes. It's
relatively low level of pain. So we start at a low level of energy to try to introduce you to the handpiece.
Kind of like when you're tapping it to go numb, and then you can
you can. Our body's desensitized, just like my butt doesn't feel sitting in this chair anymore because I've been sitting in it for a while. Your body kind of responds and doesn't feel so much pain in that situation anymore. So the important thing is we have to get you to a certain energy level with the handpiece, or else it's not getting enough of a chemical response from your cells.
Okay.
That being said, we were talking about how it's not an acute thing. There is a level of pain relief that comes with shockwave therapy. Cellularly, you release a substance called substance P, and that dampens pain responses. And I know everyone's like, oh, must be the placebo effect of somebody hitting you with this little projectile, but it's actually been seen in veterinary studies as well on horses. A horse can't tell you that they feel better. All they can do is chomp on carrots. So they don't walk away lame afterwards. They're walking more normal after shockwave therapy. Yeah.
And similar to this other treatment we were talking about, or comparing it, is it only used on the plantar fascia and Achilles tendon, or can it be used on other areas? I think we've talked before about bones and wounds.
You and I have talked about this, but there's really good literature on several things. Plantar fasciitis is a good one and has been studied very hard. Achilles tendonitis, both right where the Achilles attaches to the bone, and above that where it's particularly not well vascularized.
So we'll show these pictures here so they can see these
those
two
areas. Also, it's been used for non-healing wounds or surgery sites. So that's skin wounds and diabetic ulcers. Sometimes those things need a little jump start with some increased blood flow. And I've done that several times in the office already. And then there's the non-healing fractures that sometimes need.
That's kind of a unique use for it.
It is a very unique use, and I've seen it used for acute fractures and kind of the garbage term of shin splints. I've seen it used for that as well.
Well, interesting. Sounds like
foot pain too.
Yeah,
works very well on the ball of the foot.
On the ball of the foot. And so the big question that a lot of people that are probably watching this are thinking, well, if all the athletes are doing these great ones, the PRP and the shockwave, is it something that insurance covers at this point, or is it not covered? Who covers it?
So
that's where it comes down to for our patients.
It does. It's one of those things. Insurance companies are not in the business of getting you healthy as fast as possible. They're in the business of trying to keep you healthy. So it's unfortunately as well studied as shockwave is. It's one of those things that most insurance companies will not cover in the United States.
But in Europe,
in Europe, it's well covered. So
you can go to Europe and do treatment.
If you want to fly to Europe and do a vacation and get your Achilles tendonitis treated, you could do that. I still think we're probably
less expensive.
Unless if you fly over, you're on their universal health care, I guess. So that being said, it's one of those things that if you've tried several other modalities and it hasn't gotten better, it's not toxic to tissue the way that steroid injections are. You can only do so many steroid injections into a plantar fascia before you're looking at a rupture just around the corner. So you don't have to stay out of activities if you have shockwave therapy, which I think is one of the strongest reasons to go for it. If we do a steroid injection into your plantar fascia, we're going to tell you not to run for at least a week. we're probably going to put you in a boot too. If you get shockwave therapy, have at it.
There's no downside. Anything you want to add to the shockwave therapy, Dr. Feldman?
It's great with the buildups people have during the latter. So the big training for marathons and triathlons, whether you're training for an Ironman or a half Ironman, or just those, you spend a year of your life dedicated to a single day event, and you're putting your body through a lot to get to the race day. So if your body's not responding very well and you start showing signs of injury and fatigue or failure of some of the tissues to kind of hold up to what you're asking it to do, this is where the regenerative medicine makes so much sense, because you're helping your body get through it. So shockwave is done often in the buildup right before a marathon, maybe in the last 3 to 4 weeks, called the taper phase of that, or a triathlon, or to get somebody through the big build phase that is 2 months before the event.
And there's really no downside to it.
Really just the insurance not covering
yeah.
it, so the patient has to be willing to do it, and to also pay attention to all the little things that go with it. It's not like, have a shockwave treatment and you're healed.
And you're going to be healed.
Yeah, you still have to work hard at keeping your body as healthy as possible.
Yeah, it's very, very exciting.
Yeah, shockwave's not a license to go nuts and keep hammering 100-mile weeks. It's kind of a warning sign, get you healed, maintain, and then usually you're back at it.
And get you through it.
Weeks later.
And the whole goal of this would be to get you back quicker than you would normally
Absolutely, yeah.
get back to the activity.
Right.
You're at your same level. That's great. That's great. So we've talked so far about platelet-rich plasma and shockwave, and now the last portion we're going to talk about is very exciting. It's called amniotic membrane therapy. And this is kind of a really unique science, and I'd like both of you to contribute to this one, starting with Dr. Feldman. What is this amniotic therapy? It makes me think of a baby being born and the placenta, so tell me about it a little bit more.
Yeah, we alluded to this earlier with the platelet-rich plasma. So amniotic cells are cells taken from a placenta or the amniotic tissue, not the embryo, so not the baby. It is typically taken from mothers, healthy mothers with healthy pregnancies, patients that are screened, and there are several companies out there that take the amniotic membrane and amniotic tissue from right from the hospital. They then take that and they are able to sterilize it in a special bath.
From what I remember from biology, inside there, isn't that sterile already inside the placenta?
Yeah, but you still want to
sterilize it.
It's coming from another body.
There are the communicable diseases within there,
Mm-hmm.
but only certain communicable diseases can be passed from mother to baby or in that situation.
So if you take pure amniotic tissue from somebody and put it into yourself, there could be rejection. There could be host versus graft rejection. What the amniotic allograft is, so allograft refers to taken from somebody else. If it was from you, it wouldn't be from you, but stem cells could be taken from you. So that would be called.
Yeah, so let's talk about comparing this to stem cell if you want
Okay,
to do
yeah,
that
so
too.
stem cells would be, so there are cells that can become anything, right? You have bone marrow that produces cells. So inside the bone marrow are stem cells, and they could, if you extract some stem cells and you could then inject them into your own tissues, they could become bone, tendon, ligament, fascia, nerve. And this is really exciting part of the future and the present, really. But it takes a bone biopsy to extract the stem cells. And what you're looking for is you're looking to convert diseased and unhealthy tissue into healthy tissue that can do the job that you need it to do. So the amniotic tissue allograft is a way to take the elements that come from stem cells, and it's acellular. So basically, when they get the amniotic tissue, they wash it down and sterilize it, and then they pretty much break apart the cells. So there are not any cells in this allograft. And so therefore there is no graft, there is no chance of disease transmission. It's extremely safe. And then you're putting at a very high concentration of the materials that come out of the stem cells, you're putting it right at the source of the injury. And as we mentioned, and which we'll show you in a second under the ultrasound guidance, you can put it right at the source of the defect.
Yeah, so we'll show you an ultrasound right now of what it looks like, where the needle is going in, and then putting a little bit of that liquid in there.
Yeah, so this is an Achilles tendon that's thickened and diseased. You see some measurements here. You'll see some dark areas on either side of the picture. This is an ultrasound looking at a cross section of the tendon, and this next picture shows the needle coming in. And then lastly, we'll transition to some, you can see the actual crystal in blue and yellow coming out of the tip of the needle into the darker areas of the tendon. And the tendon really shouldn't have any dark spots in it. It should be a pretty uniform color on that gray scale that you see. Mm-hmm. That's what we see on the ultrasounds.
Yeah, and so it's great, so you can put it right where it needs to go. You don't have to guess.
And as you'll notice, it's a really small amount. And here's a big difference between the amniotic allograft and the PRP. And we were talking about getting 3 cc's of the liquid gold from the PRP, I'll call it that. The amniotic tissue is expensive. It's expensive because of, I mean, just think about how they get it and how they process it. And we carry a couple different varieties in our office. We kind of call it low potency and high potency. So one is a crystal form and the other is a liquid form. And we have to, we usually mix it with some anesthetic or some saline to dilute it a little bit, but at most we're really getting about maybe 1 cc, maybe 1.5 cc.
That's not much.
Most. It's not much. So if you have a very small area to infiltrate, perfect. You know, if you have one little defect, perfect. But if you have a larger area, you could either do the PRP or you could mix the two together. There's nothing that says you can't do that. Mm-hmm. So if you wanted the best of all worlds, and this is what we do. I mean, if you want the best of all worlds, you do it all. You know, I call it throwing the kitchen sink at the problem.
If you want to get better, you can throw everything at it.
Because there's no downside to doing any of it. It's not dangerous and it's not destructive.
Well, I think that's what we've talked about in the office sometimes. If you're preparing for one of your triathlons or 100-mile runs and something happens to you,
if I've committed a year
you're going to
of
throw
my
everything
life,
at it.
And it's not just me, it's my family is committed to this as well, because they got to put up with me. Mm-hmm. They got to put up with late nights, early mornings, and just it's a huge commitment. And you know, I'm not going to let it derail me. Or you know, I have grandparents that want to play with their grandkids and they can't. It's anybody. It's not just an athlete. Yeah. It's people that don't want to, you know, be laid up for 2 months, 3 months, and there's no guarantees with surgery.
Correct.
So you're not burning any bridges by doing these procedures, any of these procedures.
There's relatively very low downside to them.
Mm-hmm.
And there's
no anesthesia risk.
Upside.
Right.
Yeah. So these are the main regenerative therapies. I know there are a couple other we talked about slightly, some of the older ones that were in vogue for a while. Any of those you want to touch upon?
Yeah, you'll see prolotherapy is one of the things that's out there.
What is that? What are you injecting in there?
Typically it involves dextrose or sugar. You can do anesthetic, or you could just do saline. And it typically involves multiple needle sticks and very small amounts of the dextrose into damaged tissue, whether it's plantar fascia. It's used in a lot of other areas of the body as well. Yeah, I don't do it, so therefore I don't know a whole lot about it. Yeah. But there are, you know, that's one of the things that you'll see out there. And most of the people that will do prolotherapy are also doing the PRP.
These other therapies
or the amniotic tissue, because you know, prolotherapy is one of the earlier ones that have come out, and it was before the amniotic cells were available, and it was when stem cells were very difficult to extract, and it's all very costly. Sure, yeah. You know, dextrose is not very costly.
And there are places now where you can go and they will do a bone biopsy, extract those cells, and inject them in other places for you.
Maybe that's next for us too.
Yeah, and you know, it gets back.
If I have a hard time with a needle stick, I don't know what I'm going to do with that.
It gets a little bit back to what we were talking about before, though, with the quality of your own tissues. Yeah. So if I'm a little bit on the less healthy side, then the cells that you'd be able to get from my bone marrow may not be all that sporty, you know. So sometimes it's good to give it a little kick with the amniotic tissue allografts, because they have those signals that are going to get a response from your regular tissues. Those signal both stem cells and regular cells within your body to get a response, rather than doing a trephine that's the size of a pencil into my iliac crest right in my hip.
To get something.
Don't really want that myself. I'm
So
out.
let's break it down. For those that are listening to, or watching this program, the most common diagnosis we see in the office is plantar fasciitis. So when should someone seek out someone that can do these regenerative therapy treatments? Is it after 1 month? Is it after 6 months? Is it day one? Who should come to see someone that does regenerative medicine?
Well, as Ben said, most people get better, you know, and most people have met somebody that's had plantar fasciitis. Oh, try this. It works. It'll work great. You know, oh, I had a shot once and it healed me, it cured me. So, you know, there's symptoms and there's problems. And symptoms come and go sometimes. If you're not symptomatic and it's not affecting the quality of your life, you don't need it.
Okay.
You don't need it. So, you know, if you've tried the usual, and I'm a big foam rolling fan, you could do icing, you could do anti-inflammatories, you could rest. Resting is always an option. Maybe not for my patients for the most part, or me, but you know, resting is an option. But if it's affecting the quality of your life, if you don't want cortisone, or if you've had cortisone
and
before and it hasn't worked, if you're needle phobic, you know, maybe the Shockwave would be better for you.
Or if you don't want to take the time off from a steroid injection.
Right, or
if you're considering surgery too.
Considering
if
surgery.
They're saying, you know, the only option is surgery, you have to cut through the fascia or, you know, repair your Achilles. Another option to maybe avoid surgery would be one of these other options too.
Yeah.
Well, great. So I think we've explained pretty well these new types of therapies called regenerative medicine and the different uses in the body. Anything else that you want to add about this? I think this was a great conversation. I think there was going to be a lot of interest. And this by no means is a comprehensive conversation about the topic, but it's guided to help us to treat the conditions that in the past we could only treat with surgery. And if you're wanting to learn more, you can go to the website, centralmasspodiatry.com, and you can learn more about these types of treatments. So I'd like to thank both Dr. Feldman and Dr. Saviette being my guests here on the show today.
Thanks for having us.
Thank you.
Thanks for having me. Maybe we can do it again.